Good morning. My topic today is ptosis, diplopia, and squints. I'll be basically mostly talking about ptosis and diplopia. Squints is more of an eye surgeon's work, but as general doctors, you all should know how to identify a squint and how to refer. Right. So ptosis and diplopia can occur in combination, or you can get ptosis only, diplopia only. And when either a combination or alone, when they present, it is very important to examine the pupil. So we'll be talking a lot about pupil examination as well. Then ptosis and diplopia. Usually, if a person presents with ptosis, you have to look for diplopia and vice versa. If they have double vision, you have to look for ptosis as well. Even subtle ptosis, unless you look for it, you may miss it. And again, you have to look for other signs when a person has either or both of these signs or symptoms. Then you look for other signs like globe position abnormality and presence of hyperemia and inflammation. We'll see why. What are the two entities of abnormal globe position? The eye can move laterally or medially, upwards, downwards. We call it an ocular deviation. And also the globe can move from inside the orbit, either out, or it can get retracted into the orbit. What do you call when the globe is outside? That is proptosis, whereas when or exophthalmos, whereas the globe retracting back is called enophthalmos. This is the what I meant by ocular deviation. You can see with here the right eye has moved medially. When the patient is looking straight, the right eye is looking medially, while the left eye is looking straight. This is called an isodeviation. Then here, the picture below, you can see this person's left eye is looking laterally, whereas the right is looking straight. Patient is trying to look straight, but the left eye goes deviated laterally. So that is called an exodeviation. And in this case, the left cornea, you can see it is at a lower level than the right. That is called a hypodeviation. Whereas in the little girl here, you can see the cornea is at a higher level, that is a hyperdeviation. Right, I talked about globe position, and this is enophthalmos. If a person has an apparently small eye, you suspect enophthalmos. There's a bit of ptosis, but this could be due to the, since here the globe is anterior, the lid is in the correct position, whereas when the globe is retracted, the lid now has more space, so it comes down. So if you suspect, this is how you check. Just like you check for proptosis, you either look from the foot end of the bed or the head end of the bed while the patient is lying down, and you can see that this globe is definitely moved back into the orbit. The commonest cause we encounter is the blowout fracture. I'll talk more about it in a future slide. And also, you have to if it is acute, it is usually it has to be following trauma, a blowout fracture. You have to ask even for subtle trauma. Sometimes can cause blowout fracture. And if it is chronic, then it could be secondaries associated with fibrosis, like the serous breast carcinoma. Then you have if you see enophthalmos, sometimes you may have to exclude other abnormalities like microphthalmos, a naturally small eye which appears further back in the eye, and also a shrunken eye which we call a phtisical eye. Following trauma or severe inflammation, sometimes the aqueous production is reduced and you get a shrunken globe. That is called a phtisical eye. Right, so this is exophthalmos. The commonest cause of proptosis or exophthalmos is thyroid eye disease. The special feature which you differentiate it from orbital tumors on your right side, the special feature in thyroid eye disease is the lid retraction. Here the lid is retracted due to the sympathetic overaction associated with thyroid eye disease. And there are many other theories also, but usually in thyroid eye disease, usually there is a lid retraction and lid lag. In this case, where the exophthalmos is associated with either a normal lid level or a ptosis. In this particular case, there is a little bit of ptosis as well. And sometimes then this particular case, there is a globe position abnormality also. The globe has moved down. There is a hypodeviation or a hypoglobus. And this is usually associated with a problem in either the orbit, orbital malignancy, or some inflammatory mass, or a similar disease at the orbital apex. Right, I told you to look for hyperemia. This is why. In this particular case, there is proptosis, bit of ptosis, and then there is hyperemia, Cox-True vessels, vascular dilatation in the anterior segment. And this is and if you are lucky, you will be able to catch the pulsatile proptosis when you touch the eye. So this is due to carotid or cavernous fistula, which could be of two varieties: direct following trauma, or indirect due to hypertension or other vascular disease. I told you to look for features of inflammation. This is why. This is an older person who presents with proptosis, and you can see some hyperemia. Hyperemia can also occur in thyroid eye disease, but in this particular person who is immunosuppressed, this could be a fungal infection, because this patient not only has proptosis and diplopia and ptosis, he also has chemosis and severe pain. So not severe, sometimes pain, sometimes severe. This could be fungal inflammation of the sinus, which has spread into the orbit. It is very important to diagnose these patients at an early stage, because otherwise the infection can spread into the cavernous sinus and base of skull, which is then very difficult to treat. Right. So in a patient who presents with ptosis and diplopia, and you have looked for these very obvious signs of hyperemia and globe position and deviations, then what is the next important physical sign you would look for? The pupil. Right. So why pupil? The pupillary, there could be two pupillary abnormalities associated with ptosis and diplopia. One is an efferent pupillary defect. We call it, when there is an efferent pupillary defect, the two pupils are abnormal, not similar in size. That is called anisocoria. This occurs in third nerve palsy and other orbital lesions. And also you can have the other type of pupillary defect, which is called an afferent pupillary defect, which occurs again in orbit and orbital apex lesions, which involves the optic nerve. So since these structures, ocular muscles, their nerves and the optic nerve are all and the innervation of the pupillary sphincter all are together in certain areas, you have to look for efferent and afferent pupillary defects in all patients presenting with ptosis and diplopia. Right. So for you to check pupil correctly, you need to know the mechanisms. So this is a normal reaction. This person has, in the ambient light, the patient's pupils are equal in size. But when you shine a light to the right eye, both pupils constrict equally. Again, the pupil size is equal, but a reaction to light. Here, in a normal person, when the light is shown to the left eye, a similar reaction happens. The amount of constriction is similar in both instances. So we call this a normal light reaction, normal, direct, and consensual light reaction. This person who has an efferent pupillary defect has anisocoria, meaning that in the ambient light, the patient's one pupil is larger than the other. In this case, it's the left pupil. So when you shine a light to the right side, you get a full constriction of the right side, but the left eye remains dilated. This is because the sphincter or the innervation to sphincter is defective. In the lower picture, you can see when the light is shown to the left eye, the affected eye, you don't get the constriction here, but the consensual light reflex is very good. So this is the kind of picture you see in efferent pupillary defect. Then you have afferent pupillary defect, where the pupil size is equal. There is no anisocoria. The person has drawn it a little large, rather large, but it could be not. It doesn't have to be this big. It could be something like this, but it definitely won't be something like this. So there is similar pupils, similar size pupils, and when a light is shown to the right side, you get a very nice response in both sides, direct and in consensual. Whereas when the light is shown into the left eye, you see similar constriction, but you can see the amount of constriction is not similar to the similar to what it happens when you shine the light to the right eye. So there is similar response but a lesser response. That is because the left eye has poor afferent innervation, or the left optic nerve is defective. Right. For you to remember how you get the direct and consensual light reflex, you need to remember this picture. There you shine a light to the left eye. You have the nasal and temporal retina. The fibers from the nasal retina goes into the optic nerve and crosses in the chiasma, so that it goes into the opposite side pretectal nucleus, whereas temporal retina takes the light in, and through the optic nerve it goes into the same side, because it doesn't decussate, it goes to the same side pretectal nucleus. And these pretectal nuclei in turn innervates both Edinger-Westphal nuclei. That is why, and then each Edinger-Westphal nucleus sends fibers to the third nerve, the inferior branch, and since each Edinger-Westphal nucleus is getting responses from both pretectal nuclei, you get this consensual reflex as well. Now, so in a patient with ptosis and diplopia, you have checked the pupil and come to a conclusion about the pupil. What do you do next? You have to do a thorough extraocular movement examination. So extraocular movement examination is very important for an eye surgeon, but it is also important if you're in neurology or even in general medical unit. In even any other units, it might come useful if you learn the extraocular movement examination correctly. In an adult, before start examination, you ask the person to indicate diplopia and direction of image separation. But in children, what I meant by direction of image separation is either horizontal or vertical. But in children, you can't get this information. You simply don't ask them. Right. So when you start doing the extraocular muscle movement, what you normally do, what you're probably very familiar with, is the checking of smooth pursuit, where you give a target like a pencil or your finger and ask the person to follow it. So you will be checking for the slow eye movements. If that is normal, you have to go for examination of saccades. Now saccades, you need two targets. You give one pencil and a finger, or like two pens, two different color pens, and ask the patient to look from one to another quickly in rapid succession. I'm sorry, I didn't want to put videos here because it takes time, but I advise you to go to the internet and look for extraocular movements. You'll get how to check the smooth pursuit and saccades. Just see it for once, and you will remember it for the rest of your life. So saccades, the importance of saccades comes when you are dealing with something like internuclear ophthalmoplegia, where the smooth pursuit movements will be normal, and even the saccades may be normal at the beginning, but it will be slow. That is the earliest sign of internuclear ophthalmoplegia. That is why it is important for you to learn how to check for saccades. And again, in many extraocular movements, you have to examine the convergence because sometimes it is innervated in a different manner, especially in internuclear ophthalmoplegia. The convergence can be normal, while the medial rectus will not adapt in other conditions, in saccades especially. Right. So while you are looking for extraocular movements, you have to keep a watch on any aberrant movements. You can get like nystagmus or features of aberrant regeneration. I won't be discussing nystagmus because it is a very extensive subject. You probably learn it in your neurology, but we'll be talking about aberrant movements. Then you have to look for fatigability, especially of the ptosis, and also extraocular movements. Sometimes you can see the fatigability, and the patient might tell you that the diplopia image separation is more as you go by. The passive eye movements, again, you have to look for a video which is called Dole's eye maneuver. This is more neurologist work where the ocular muscles are normal, muscle innervations are normal, only the supranuclear control is abnormal. So there's nothing wrong with the eye muscles or their innervation, but it is these things happen when there is supranuclear disorders. Right. Now, what is this palsy? Now, this is the kind of picture you get when you want to show extraocular muscle defect or any nerve palsies. This is called 9 cardinal positions. You have to take the patient. This is the straight in the center. You get the primary position. This is elevation, depression, and lateral gaze, left lateral gaze, right lateral gaze. Like that, you have to take 9 cardinal position. Like right lateral gaze in elevation, right lateral gaze in depression. Like that, right? So if you look at the first, you always look at the central picture. You get some idea from the central picture, and then so that way you can next quickly look for the suspected abnormality, right? So this patient, you can see that this cornea is closer to the nose than the other side. The right cornea is in the normal position, whereas this has a deviation, or it looks convergent. So the defect should be somewhere here. The lateral rectus may be defective in this patient. So to confirm, you look into the that side of the picture, and you can see that while this is coming all towards to the corner of the palpebral fissure, this is not going that much. You can see that this is a lateral rectus palsy, which is shown here. Even in elevation, this is not moving. Even in depression, this is not moving to the lateral side. So there is a problem with the lateral rectus. And what is the nerve involved? It is the 6th nerve, right? In a person presenting with lateral rectus palsy, this is the most important thing you should look for. Once you have done all the other muscle involvement and also the pupil, you have to do that beforehand. You have to dilate the patient's pupils and see the inside, because this could be a false localizing sign, which is due to increased intracranial pressure. You can get a 6th nerve palsy. I will tell you why you call it a false localizing sign. So you need to look for papilledema in all patients with lateral rectus palsy, even if they are diabetic, and you know that it could be a vascular defect. Right. This is why you get a false localizing sign in intracranial hypertension, because the 6th nerve starts in the pons and goes up the climbs up the clivus, and here it turns. So there is a little at this turning point, it can get kinked if the intracranial pressure is high. So why we call it a false localizing sign is that the problem is not at the clivus. It is due to the raised intracranial pressure, and being vulnerable at this point, the 6th nerve is the first one to get affected, although rarely you can get 4th nerve affection as well in patients with papilledema. Now this nerve then goes through the cavernous sinus and enters the orbit through the superior orbital fissure, and goes into the lateral orbit and supplies the lateral rectus muscle. That is the only muscle it innervates. Right, when you have a 6th nerve palsy, you have to look for all the cranial nerve involvement, but if you see 5, 6, 7 and 8, then this could be 2 things mainly. One is a CP angle tumor, where you get the 5th, 7th and 8th also involved. So all patients with 6th nerve apparently isolated 6th nerve palsy, you have to check for hearing, otherwise you will miss 8th nerve palsy, and you have to look for corneal sensation. When you say 5th, you have to check for ophthalmic, maxillary and mandibular divisions, but the first one to go is the corneal sensation. So it is very important in all those patients, although you may not like, it may be unpleasant for the patient, all patients with 6th nerve palsy, you have to check for corneal sensation. Another condition that can come with the same combination with 5, 6, 7 and 8, they can have a horizontal gaze palsy and central honors, that is a Fovili syndrome. Here the lesion is here, which involves the sympathetic neuron, sympathetic nerve, and then the other nerve nuclei. That is Fovili syndrome. Whereas 6th, 7th and a contralateral hemiplegia due to the involvement of the pyramidal tracts here, you can get Millard-Douglas syndrome. These things you will mostly see in neurological wards. The other important entity is internuclear ophthalmoplegia. The cardinal feature of unilateral internuclear ophthalmoplegia, it is slowed adducting saccadic velocity. It's important to remember that initially the muscle movements may be normal. There is slowed adducting saccadic velocity. The eye with the slowed adduction may have limited or a full range of adducting movements, as I said earlier. There would be nystagmus of the abducting eye. Then there is convergence the convergence may be spared, but it may be disrupted, especially in cases where there is bilateral involvement. We call that Webino, wall-eyed bilateral internuclear ophthalmoplegia. Wall-eyed because the two eyes don't converge, as if the patient has a wall in between the two eyes. So in those patients, the convergence may be spared or may be disrupted. There is another entity called 1.5 syndrome, where you get a one-sided unilateral internuclear ophthalmoplegia with the ipsilateral horizontal gaze palsy and same side as internuclear ophthalmoplegia. I'm sorry, I have not put the anatomical explanation slide. I think you will have to add it on your own. Find it from your textbook and add it here. Right, now we move on to the fourth nerve. This is a superior oblique palsy. Now, since it is a difficult one to find out, I have already given you the diagnosis, but which side is it? Can you guess? Look at the center picture, which is the most important picture, and you can see, although the person should have taken it with a straight nose like that, there is a natural tilting of the head. That is why nose looks a little slanted this way. So there is a natural tilting of the head to the left side. So you think if this is superior oblique palsy, it causes tilt to the opposite side. So you look for the right superior oblique palsy, and this is the place to look for at the beginning, right? So you look for superior oblique. One thing to remember about extraocular muscles is that the recti do as the name implies, like the superior rectus look up, inferior rectus look down, whereas obliques, they are obliques and dishonest. So they look, they don't do what they say, right? So although the superior oblique, you might think it should elevate, it doesn't. It depresses. Likewise, inferior oblique elevates. So there is a mixing up of or a little trick they are doing. They are doing the opposite, right? So superior oblique, you expect it to depress the eye. So this superior oblique depression, you can see mostly in the adducted position. So you see here the superior oblique depression, which is not as good as this side. You can see this upper corneal level is lower in this because the muscle that is depressing the eye in abduction is the inferior rectus muscle, which is functioning here, whereas the superior oblique, which should depress, is not working here properly. So it is a superior oblique palsy. So eye surgeons, sometimes we do, as eye surgeons, we do the 3-step test to find out the lesion. First, you find the hypertropia, the side of hypertropia, whether it's the left hypertropia or the right hypertropia, and then you look for differences in the right and left gaze and see in which gaze the hypertropia is greatest. Then you see, then you tilt the patient's head and you see which side, when tilted to right or left, the hypertropia is worse. This is a little confusing. I advise you to read this carefully and try to remember. But if you just remember, right fourth nerve palsy causes right hyperdeviation that worsens on left gaze, and right head worsens on left gaze, worsens on right head tilt, and also worsens on down gaze with a relative excyclotropia of the right eye. That should be enough. Right? Because inferior rectus, other recti palsy, other vertical recti palsies are not very common, and medial and lateral rectus palsies are very obvious. Right. So here we have more than one muscle getting affected. Since we have already discussed 6th and 4th, you would already know that it could be a third nerve palsy. So you can see that the right, there is lid level abnormality, there's right ptosis. And if you look carefully, you can see that the left pupil is smaller than the right is larger. This is the elevation, and you can see there is a very definite defective elevation, and depression is also very much affected. The lateral rectus should be normal, so abduction is normal in that time, right? The lateral rectus is moving normally. Here somebody is holding the lid up in the down gaze positions because otherwise the ptosis will cover the eye movements. Here you can see the medial rectus is not so bad in this person, and in this particular patient you can see the superior oblique is probably not doing its work, right? So this could be a superior oblique palsy, as well as it could be due to the inferior rectus not working here, which could be manifested as abnormal and with a bit of little medial rectus restriction. It could be an abnormal position due to those two, or in those patients you have to specifically look for superior oblique palsy, because these two nerves, the third and fourth nerve, travel together in certain areas like in the cavernous sinus also, and near the brainstem where they exist also they are sometimes close together. So this could be either coexistent superior oblique palsy, which you should look for, also could be due to a little bit of medial rectus and inferior rectus not working properly. Right. When you come to third nerve palsy, when you diagnose third nerve palsy, you have to check all the components of third nerve. It has two branches. Upper branch supplies the levator pathoides superioris and superior rectus, whereas the lower branch supplies the medial rectus and inferior oblique. It is the nerve that carries innervation to the inferior oblique, also carries the innervation to iris sphincter and ciliary muscles. So the pupillary abnormalities occur when the lower branch or the whole nerve is affected. Right. I stress always, whenever I am doing a lecture on these eye movements and ptosis and things like that, I always stress to examine the pupil. Pupil examination is a very important part of a person's neurological examination. So what happens to the pupil in third nerve palsy? It should get larger because sphincter is not working, so the dilators are overacting, so the pupil dilates, and it is a efferent defect. It is an efferent defect because the third nerve is the one that is affected and the sphincter is the one that is defective, not the optic nerve. Right. Now these are two patients who present. The top picture shows an elderly lady who is diabetic and hypertensive coming with complete ptosis, and when you lift the lid up, you can see that the eye is laterally deviated and there is a complete third nerve palsy here. But the pupils are equal. And this younger lady is having a little bit of ptosis, you can see on the left side, but the pupil is larger here. You may not see it properly in this picture, but let me say that the pupil is larger. You can see the brow elevation due to the ptosis. Although the ptosis is not marked, you can see this brow elevation trying to compensate for the ptosis. So if you have a famous question is if these two patients arrive in the evening and you have one slot only for imaging, which one do you want to send for imaging? Which one do you give priority? The younger lady with mild ptosis or the elderly lady with complete ptosis and complete third nerve palsy with pupil normal? Right, it's obviously the younger lady, because this could be pupillary involved is usually the more dangerous one. I'll tell you why later. And also in this lady, if you say this in the history, very likely this patient develops all these features together. The ptosis, and sometimes they don't say diplopia also because the eye is completely covered. Although there is deviation, they may not say diplopia. So this lady, everything happened at the same time, but this lady, there's initially a little bit of ptosis and a little bit of diplopia gradually developing. We'll see why, right? We'll see why later, but now for the time being, initially, I will check you to stress the importance of pupil checking. I always give this slogan, check pupils to save lives. Now, I know this is not eye surgeon's work to observe the head injury patients, but in your general ward, if you are examining, I have come across various places where I have worked before. When I go to see these head injury patients, there is this chart, GCS, and in that they say pupil is normal. But when an eye surgeon examines, you can see that there is a change in the pupil. I have seen one or twice abnormal pupils, while the pupil they have checked pupils. They have marked that pupils are normal. So important for you to stress to your nurses also to do this examination carefully, because the sole reason why you do pupillary examination is to detect this uncal herniation at the earliest possible time. The first thing to go is the pupillary nerve, but initially there should be, although you expect the pupil to dilate, the initial phase due to irritation of the third nerve, you can get a pupillary constriction, which is transient and followed by pupillary dilatation. So if you catch the person at the pupillary when the changes occur at the pupillary range, that is the time you have to prepare this patient for emergency neurosurgery, because an expanding extradural hematoma is now is about to cause uncal herniation. The other instance where pupil examination is very important is in patients whom you suspect posterior cerebral artery aneurysm. There, you get a third nerve palsy, like in that the picture of the younger lady there. You get gradual onset ptosis and extracortical muscle palsy, and this is the reason enlarging aneurysm sitting on the third nerve. Right. So you may wonder why you get pupillary abnormality in the partial third nerve, whereas in a complete third nerve due to vascular abnormality or vascular defect like diabetes and hypertension causes complete external ophthalmoplegia but no pupil involvement. This is the explanation. The pupillary fibers travel this is the cross section of a third nerve. The pupillary fibers travel dorsally and peripherally. So that is supplied by the pial vessels. The pial vessels are sitting on the nerve sheath and send branches into the nerve. Space occupying lesion can compress on these pial vessels, so the blood supply is impinged and you get a pupillary defect. Whereas if you get a clot in this vasa vasorum, which is supplying the rest of the nerve, that is this ventral and also ventral and central. So most fibers are affected. The fibers in this are affected, but because of this dual nerve supply, dual vascular supply, the peripheral and dorsal pupillary fibers are spared. So that is why in medical third nerve palsy, you don't get a pupillary affection. There are some pitfalls when you try to examine with a torch, because some of these elderly patients especially have undergone IOL surgery. So they can, during the surgery, surgeon may have damaged the sphincters. So you may get a different pupillary defect, which is not due to this pial vessel compression. In diabetic patients, you get some anisocoria, which sometimes confuses your findings. And there is another condition called eye condition called pseudoexfoliation that also produces a coexisting or pre-existing anisocoria. The other important thing is, once you have a EPD, you may not be able to check for RAPD. For that, we have a test called reverse Marcus Gunn test. I mean, it's nothing; it's just a fancy word, where you shine the light to the RAPD eye. The eye that has, the efferent pupillary, the dilated pupil side, you look carefully for the other side to see whether there is less reaction compared to what you see when you shine the light to the right eye. So this is called reverse Marcus Gunn test. By that you can if you do that, you will not miss the coexisting RAPD. Few features to differentiate between the compressive and vascular. The compressive is gradual, step by step appearance of symptoms and signs, whereas vascular, everything happens at the same time because it's a vascular event. Then compressive ones are usually painful. About 80% are painful due to posterior cerebral artery aneurysm. Vascular ones are generally painless, but they say sometimes diabetic patients complain of pain when there is double vision, and also sometimes patients non-discretely say pain when they have headache because of the double vision. Also compressive, as we said, there is an efferent pupillary defect. Efferent pupillary defect is absent in vascular unless there is coexisting diabetes, pseudoexfoliation, and damaged pupil during cataract surgery. The presence of aberrant regeneration is an indication of compression. Because the compression happens slow and over a period of time, whereas presence of vascular disease is more in support of vascular events. This is what I meant by aberrant regeneration. You can see this patient has ptosis and elevation defect here. So the patient is having a third nerve palsy, incomplete third nerve palsy. And what you see here is when the patient is trying to adduct, look to medial side, the lid is elevating. Because what the fibers that should have regenerated to form the medial rectus nerve now is going to the levator palpebrae. So there is aberrant regeneration, a mixing up of wiring, and while the patient is trying to adapt, the lid elevates. This is called aberrant regeneration, which is the commonest type of aberrant regeneration. So always when the patient is moving, especially in recovering third nerve or a gradual onset third nerve, if you see aberrant regeneration, you have to suspect a space occupying lesion. There are few syndromes associated with third nerve palsy. You can have the important thing to remember is in a nuclear third nerve palsy, you can get a third nerve involvement and a bilateral ptosis. The opposite side has ptosis as well as a superior rectus palsy. There is bilateral ptosis and contralateral superior rectus palsy in nuclear third nerve, in addition to the unilateral features of third nerve palsy. This is because of the innervation. The levator palpebrae is a central nucleus, so it has common innervation, and the nerve to superior rectus, the fibers to superior rectus cross from the opposite nuclei. Fascicular third nerve palsies are associated with a few distinct clinical syndromes like Weber, Benedict, and etc. These are due to the various involvement of different companions or relations. For eye surgeons, it is very important, the orbital apex syndrome, because these patients usually present to the eye surgeons, unlike other sixth nerve and fourth nerve palsies are referred to mainly neurologists, but whereas these patients present to us because the problem is mostly affecting usually there is proptosis because of the compression at the orbital apex. Something is pressing there, and since all these nerves, the optic nerve, the trochlear nerve, superior division and inferior division of oculomotor nerve, the nasociliary nerve which supplies the cornea, and the sixth nerve, all are together. Some of them are within the circle of Zinn. Trochlear nerve is outside, but it is also close by. So you get this a combination of muscle palsies with the afferent and efferent pupillary defect due to all these structures staying close together at the orbital apex. This could be either due to infection, inflammation, and infiltrations. All can cause multiple nerve palsies together. Right. Again, when you are talking about muscle palsies and squints, sometimes the patient actually present with, rather than diplopia, they present with an abnormal head posture. They have to tilt the head, especially children. They don't know to discuss to explain diplopia, so they acquire a natural head posture so that they compensate for diplopia, to avoid double. Right, so they look into the direction of node of diplopia. For example, if a person has left sixth nerve palsy, the diplopia will be mostly in the left gaze. So the patient, instead of looking with the eyes to the left, instead of looking to the left with the eyes, they turn the face to the left. So if a child has if the parents complain that the child is suddenly looking to the left and tend to keep the face turned to the left, then you have to look for left lateral rectus palsy. Likewise, if there is diplopia in down gaze, like in superior oblique palsy, the child will have chin depressed. Even adults following road traffic accidents, they can have a depressed chin to compensate for down gaze diplopia. When there is diplopia due to excyclotorsion, the excyclototic muscle is the superior oblique. Again, you get the head tilt to the opposite side. Right. This is an interesting clinical question I have been asking. These two people are following a road traffic accident. This is the owner who was sitting in the back seat, and this is the driver who was sitting in the front seat. So both are complaining of vertical diplopia, but they have two different pathologies. The driver has a blowout fracture. This is an explanation of blowout fracture. When there is suddenly something which hits the eye, which is smaller than the orbital opening. So then the force is directed right into the orbit because the bones are not protecting here, right? The bones, it is smaller than the bony orifice. So the force is directly exerted on the globe, and the globe moves backwards to a certain extent. But when it if the force is too much, then it has to, the weakest orbital wall gives way. The weakest orbital wall is the inferior wall. So you can get orbital contents. This force is enough to fracture the thin orbital flow, and so the contents can jump into the maxillary sinus. So if there are a lot of other fractures, like sometimes it can cause other fractures of the rim and all, then it is the duty of the work goes to OMF surgeons. But if it is just a blowout fracture, also sometimes the patients may come with a very nice white eye, especially children, when there is not enough force to cause contusion. Sometimes the eye is not even red, it's a nice white eye, but they have diplopia or a abnormal head tilt, so that you have to look for, ask for any subtle trauma like a book edge or a doorknob or even a big person's thumb. So things like that can cause this, a subtle thing can cause weak fracturing of this weak inferior orbital wall or the floor. So this is what you see in the CT scan. You can see the orbital contents in the maxillary sinus. These patients need steroids, and to see this you need to order X-ray sinus view, not just the X-ray skull, lateral and frontal or whatever. You have to ask for the sinus view if you are only having X-rays, but always you may have to do the CT scan for medical legal purposes, and also proper diagnosis, and also for the surgeon to decide how to approach. If necessary, if the fracture is very large and significant amount of orbital contents have gone into the maxillary sinus, you may have to operate these patients. Otherwise, sometimes they can manage conservatively. Right. What happened to the owner? The people in the back seat of a car is subjected to sudden deceleration because of the sudden brake. So sudden deceleration causes this slender trochlear nerve to get damaged, mostly a neuropraxia, but it can cause more permanent damage. So the important thing you can see is that the patient has a head tilt. Although he doesn't have any features of direct trauma here, you don't think that it is malingering, but he has this head tilt, which indicates that he has a right superior oblique palsy. Right. Once you have diagnosed third, fourth, sixth, or gaze palsy or whatever, that is only an anatomical diagnosis. You have to do a quick cranial nerve workup to see associated other neurological findings, so that you can advise the radiographer which areas to look for when you order the neuroimaging. And to get a pathological diagnosis, you have to ask a few questions in the history about headache, retroorbital pain, which comes in papilledema and also in orbital apex syndromes, presence of diabetes, recent history of recent stroke, encephalitis, and in systemic diseases like TB, widespread systemic diseases like TB, sarcoidosis, malignancy, which can affect the nerve tissue, and other neurological diseases. Now, what is this test? This one, you can see this person is looking at his own finger at a higher level. So this somebody has asked him to keep his eye elevated for a while to look for fatigability of ptosis. This is a quick test to do. You have to keep the eye in the elevated position for about 30 or 60 seconds. So once you are suspicious of fatigability, I think you know the diagnosis. It is you are looking for myasthenia. The next test to confirm is the simple test we can do is the ice pack test. This is how you do it. You have this patient with a ptotic left lid, and you put you put some ice on the eye. Don't put ice nakedly on just plain ice on the eye. Wrap it with some cloth, because otherwise it will damage the cornea. You put it on the closed eyelid, and then you can see if you have kept it for 2 or 3 minutes, then you get a improvement of the ptosis. This is fairly a good test to check whether it is myasthenia, right? So improvement of ptosis is what will confirm your myasthenia. The basis of myasthenia is that you have acetylcholine receptors, the neuromuscular junction, where you have at the motor plate, they release acetylcholine, and there is acetylcholine receptors here, and they this is taken up, and normal neuromuscular transmission occurs, and the muscle movement occurs. In this case, in myasthenia, we're talking about levator palpebral superioris. When there are antibodies against these receptors, the acetylcholine cannot occupy the receptors. So what happens in cold? Acetylcholine esterase is inhibited, and also in tensilone, acetylcholine, when you are using tensilone, acetylcholine is esterase is affected. So you have more acetylcholine molecules to interact with the receptors. That is why it gets better with cold test. Right. Why is it important for you to diagnose ocular myasthenia gravis? Because 80% of ocular myasthenia gravis patients will develop generalized myasthenia within 2 years. And sometimes the patient may be already having systemic disease because they may come to you with the more alarming ocular things like ptosis and diplopia sometimes alarm people. But if you ask them, they may be having difficulty during swallowing, walking, and breathing, which may be they may be putting to etc. tiredness at work or old age and things like that. But only if you ask, they will come out, yes, I have a problem swallowing. After a while, it becomes more and more difficult to swallow, and yes, I have walking difficulty, or yes, I have some breathing difficulties. It is very important you to diagnose these conditions, and if you diagnose ocular myasthenia in these people, it could be a neurological emergency, because anytime their respiratory muscles can go into failure if they go into myasthenic crisis. I think you know what Eaton-Lambert syndrome is, where again there is fatigability, but the repetitive nerve stimulation test you do to confirm myasthenia is normal in Eaton-Lambert syndrome. That is a condition associated with lung carcinoma. Right. Now, sometimes you may encounter patients who has ptosis and extraocular muscle defect, but they say no double. You'll be very irritated when you think that they have to have double vision, but they say no double vision. Right. So these are the few conditions you have to think of. Always you have to check the vision in eyes, because in cases like orbital apex syndrome, because the optic nerve is damaged, the patient's vision in that eye may have gone earlier. So when the muscle palsy occurs, when they present with muscle palsy, the vision in that eye, the vision is not good in that eye, so they don't see the double. And sometimes when there is complete ptosis also, when that happens first, or that happens concurrently with the muscle palsies, they will not say double vision, they will only complain of ptosis. Then in children, especially when they develop compensatory head posture, again they don't have double vision, because they do the head posture to avoid double. And patients with gaze palsies, because the alignment doesn't change. In gaze palsies, when you have a right lateral rectus or right lateral movement defect, you have a left medial movement defect. So the eyes are together, they don't move out of alignment. So they don't have double in gaze palsies. Like in internuclear ophthalmoplegia also, sometimes they don't complain of double vision. And there is another condition which sometimes you might encounter, where they are totally frozen eyes. There is bilateral ptosis. Although the visual axis is not affected in this case, the patient will not have double vision, because the eye don't move at all. You can see there is no depression, no elevation, no lateral gaze, no left gaze. Everything, all the pictures look like as if they are taken in the primary gaze. You can see a little bit of lateral movement here spared in this person. Other than that, both eyes are totally frozen. Another thing you have to think of, especially in candidates who have the people who want to get their driving license, especially if they have lost the license following a road traffic accident, even if they have a muscle palsy, sixth nerve, traumatic sixth nerve or fourth nerve, third nerve, whatever palsy, they say there is no diplopia, because if you say diplopia, we can't give them the driving license. So you have to think of that. If they continue to say diplopia, if they continue to say no diplopia, but you think that they should have diplopia, then it is a very difficult decision to take, because when people have diplopia, we can't give driving license. Right? People who have ptosis only, and you have done your extraocular muscle movements, and you can't see any extraocular muscle involvement. These are the few things you have to think of. Myasthenia can present with ptosis only. Horner syndrome is not a muscle problem. It's a sympathetic affection there, so you don't get an extraocular muscle palsy. Myotonic dystrophy, initial phases, they will only have bilateral ptosis. And the other thing is mechanical ptosis. Turn the lid inside out and look for scarring and tumors before you send the patient, local tumors, before you send the patient for imaging. Patients who have had cataract surgery or other prolonged eye surgery can have injury due to the speculum we use to keep the lids apart, or any other traumas also. Trauma or surgery can cause levator affection without other extraocular muscle affection. Senile ptosis or aponeurotic ptosis is another cause of having just ptosis, which could be asymmetrical or symmetrical, and no extraocular muscle defect. We talk a little more about Horner syndrome. There is partial ptosis with ipsilateral meiosis and upside down ptosis. The ptosis, mild ptosis, and the upside down ptosis causes smaller eye in the affected side, and the pupil is also smaller. So this is a smaller pupil in the smaller eye. Then you have to look for ipsilateral facial anhydrosis, which will be seen only in the forehead in cases of third order neuron affection. The important thing to remember Horner syndrome is, if a person with Horner syndrome comes with acute pain, then especially if it is radiating to the jaw, you have to suspect carotid artery dissection. So you have to emergency, you have to consider it as an emergency. This is how you localize the lesion. The first order neuron comes from the hypothalamus to the brainstem, into the spinal cord, where it synapses with the second order neuron, which goes up in the sympathetic chain, and it then synapses here again in the superior cervical ganglion, which then goes to the sympathetic supply up to the internal carotid, and one part going to the sweat glands to the external carotid arterial plexus. Right. The other condition I talked to you about is the myotonic dystrophy, where these patients have a typical faces. They have a very uninterested facial appearance. You might get a little annoyed at these patients without knowing that they have a if you don't think about this muscle palsy, the facial muscle weakness they have, right? So they have bilateral ptosis, and interestingly, they also can have other associated eye conditions like pigmentary retinopathy and Christmas tree cataracts, and a little bit of ophthalmoparesis. The pupils are myotic and they have low intraocular pressure. Since this can be associated with diabetes, you have to do the blood sugar test, and also cardiac arrhythmia abnormalities, cardiac arrhythmias. So you have to do ECG also. I think you all know about the grip in these patients. They keep your hand, if you shake hands with them, they will keep on holding to your hand, because it is difficult for them to relax the hand muscles. That is another special feature. Now I talked to you about the aponeurotic ptosis. These tired old people sometimes have this ptosis. The important thing is, you can see the lid wrinkling, the forehead wrinkling. That is because of the they are trying to overcome the ptosis, which tend to cover the visual axis. They try to either elevate the head or wrinkle the forehead, so that frontalis muscle helps to elevate the lid a little bit, right? So these people, they also can have frontal headache. That is because of this continuous muscle contraction of the forehead, and they sometimes complain of tired eyes. The other important thing, apart from the wrinkling of the brows, is the higher skin crease. That is because the levator has now gone off. Levator has either completely dehisced or very lax. This is senile aponeurotic ptosis. In desperate cases, you may have to do surgery to elevate the lids. So they do very well with the corrective surgery. Right. Now we have talked about ptosis only. Diplopia only, again, is it apart from third nerve, the possibilities? What are the possibilities? Sixth nerve, fourth nerve, internuclear ophthalmoplegia, anything other than third nerve affection. If the third nerve is affected, you are likely to have ptosis. So the unlikely things are third nerve palsy and also myasthenia, because it is very uncommon for myasthenia to present with only diplopia without ptosis. Now you encounter a problem if people sometimes have diplopia, but you can't see any extraocular abnormality. Then this is what you do. Right, you go for the history. If the patient says double when I look far, this could be a lateral rectus palsy. The innervation is sixth nerve. Then sometimes they say double when I look down. That is a superior oblique palsy. again, you remember the innervation, it's a fourth nerve. What would be the history in third nerve palsy? It could be anything. It could be double looking far, double looking down, double looking near, because if the medial rectus is affected. So like that, third nerve palsy will not have a fixed history. Right. So there are sometimes the patient will not explain them. These are the different ways of explaining. If the patient say can't go down steps, then that is looking down diplopia, that is superior oblique. Sometimes they say look like as if TV is malfunctioning, like a ghost image. So they don't say double vision. Sorry, they don't say double vision. Instead, they say a ghost image. This is one story I've been telling each batch. The little girl who said her only problem was she didn't have problem, no diplopia. She found, the parents found that she's complaining when she's trying to read. She found difficulty in reading because there was the eyes were the eyes are deviating. When looking down, the eyes should come together, but this child has I think this child had sixth nerve palsy. She had diplopia looking down, very unusual, but since she had a ESO deviation, I examined for sixth nerve palsy. I couldn't see sixth nerve palsy much of a sixth nerve palsy. It was a very subtle sixth nerve palsy, but when I examined the fundus, there was papilledema, and actually the child has an intracranial tumor. So very subtle symptoms, but the underlying diagnosis should not be missed. So sometimes you have to get a clue from the image separation. If they say horizontal image separation, then it has to be either medial rectus or lateral rectus. If they say vertical image separation, it has to be a superior or inferior rectus. If the images are slanted, in horizontal, it is like a equation mark. It's like number 11, two vertical lines. In vertical, it's like equation mark or samana lakuna. But in torsional, they say one image is straight, the other image is tilted. So you know that it is an oblique muscle, or oblique muscle. But what if they say blurry image around the proper image? Then it has to be a refractive error. That is usually a refractive error. So sometimes patient take you for a ride saying double vision, but when you ask what is the kind of image separation, then they say it is just a little ghost image around the proper image, which is due to a refractive error in one eye. Right. So with that, we move into the little topic on monocular diplopia, which usually present to eye surgeons. The diplopia is more marked when one eye is closed. In normal diplopia, the thing you normally call diplopia, both eyes have to be open and have good vision to have developed diplopia. But here, diplopia is more marked when one eye is closed. This is due to ocular anatomical defect in the affected eye. Either a large refractive error, a corneal scar, certain types of cataracts, retinal detachment, retinal scars, or any ocular abnormality, anatomical defect can cause monocular diplopia. Right. Now, again, if the patient complains of diplopia only, there are a few things you have to look for. The eyes, you have to see whether the eyes are normal or whether it is an abnormal deviating position. Even if there is no muscle palsy, sometimes if there is a squint, although the patient says squint has been there for a long time, if it is decompensating recently, they can develop diplopia. In general, you have to remember that squints normally present with ocular disalignment rather than diplopia, whereas muscle palsy is present with diplopia rather than they sometimes may notice the misalignment, but it is usually with diplopia. But squints also, long-standing squints, when they decompensate, they can develop diplopia. So the few, I'll go more about in the next slide. And also sometimes nothing is abnormal, but you might notice that globe position is abnormal. When the globe position is abnormal, again the images are falling into the two eyes differently, so they can develop diplopia. They can complain of diplopia. This is a test we do at eye hospital. Here the eyes are dissociated artificially by asking the patient to wear red in one eye, green in one eye. So you can then they show a picture and ask the patient to mark when they give the target, ask the patient to mark the image. So you then put these two together, all these lines together, they put the dots and they connect them together, so you get a picture. This is called a Hess chart. This will sometimes show you subtle changes, things which you can't see with normal eyes. Because the patient has good image separation, they can put it on the paper. So this is called a Hess chart. You can see the subtle defects with it. And sometimes if you are very familiar with the Hess charts, if you are doing examination of Hess charts very frequently, you will sometimes can tell the pathology. You can see that normal dot line is this dotted line, normal line is this, and there is deviation. This is an underaction. If it is moving inwards towards the center, it is an underaction. Whereas in this side, you have overaction of its yoke muscle. The other muscle that is acting with it is overacting to compensate this muscle. There is something to do with the innervation of the extraocular muscles. So this is you can see underactions and overaction. And also for monitoring, sometimes when say for example, if you have a superior oblique palsy or a lateral rectus palsy following trauma, we know that sometimes they're difficult. You can't repair them immediately. So you wait for the spontaneous recovery to occur, and you think of surgery only if the diplopia is not getting corrected with time. Right, a little bit on squints. Squints are defined as abnormal alignment of the two eyes. Now, you need to understand squint. You need to understand the yoke muscles. Yoke muscles are like the two eyes. We have one muscle always pairing with another muscle. Like for example, if you are looking to the right, your right lateral rectus is working together with the left medial rectus. So those two eyes are moved in the same direction. So likewise, each lateral rectus is in yoke with the opposite side medial rectus. The two superior recti work together. But if you are looking to a side, the right superior rectus is working with the left inferior oblique and vice versa. In depression, the left inferior rectus is working with the right superior oblique. So like that, there is always a yoke pairing. So I advise you to draw a picture diagram or find it in the internet of the extraocular muscles, how they move, and then find your yoke pairs there. Right. So coming back to squints, the squints can be constant or intermittent. Intermittent squints can later become constant. Especially if they have starting in early childhood intermittent squints, then late childhood they can develop constant squints. Early childhood constant squints are the most dangerous because they can cause this condition called amblyopia. Right. So in constant squints, the fixation is monocular because one eye is always looking straight, the other eye takes up fixation and continues to fixate. The person continues to fixate with that eye only. But some people have alternating fixation. That means when one eye is straight, the other eye is squinting, and that eye, the second eye, the squinting eye, sometimes takes up fixation when the other eye goes out of alignment. Also, horizontal squints are commoner than vertical, but if the patient has vertical diplopia, or what if they complain of head tilt, then you have to look for vertical misalignment. This is a congenital esotropia. This is a exotropia. And you have other two tropias here. Again, I'm showing you hypotropia and hypertropia. So when you are doing this, what you need to look at now, these are I have put very obvious ones. What you have to look at is this corneal light reflex, which we call the Hirschberg's test. You shine a light to the root of the nose and you notice the corneal light reflex. Here you can see this is straight. This one, the light reflex is lateral. That means the eye has moved medially. Like here, this is straight and light reflex even doesn't touch the cornea because eye is so out of alignment. Here you see the two light reflexes. This is at one place, this is at a lower level. So this is at a higher level in the cornea because the eye has moved lower. Here again, you can't even see the light reflex. So the next test in a squint is the cover test. This is how you do the cover test. You ask, this is for the near cover test. You give a near target and close one eye with this thing called occluder. You can use even the back of your hand, which is not nice, but we have nice occluders. You cover one eye, then you cover the other eye, right? You cover one eye, wait a while, look at the response here, and you cover the other eye, wait a while, and you move to this side. And then you move it in rapid succession to do the alternate cover test. Right. So this is what you observe in the cover test. Now, this child has a left exotropia. And when you cover the fixating eye, this eye comes back to normal. Sometimes it doesn't come back to normal, which means that eye vision is poor and some sort of permanent damage has occurred. But if the eye is fixating, you are happy because the fixation ability has been retained, and surgical repair may help with correcting the squint as well as improving the vision. Right. The important thing is amblyopia, because amblyopia is a condition where unilateral or sometimes bilateral. In esotropia, in congenital esotropia, sometimes you get bilateral amblyopia. Is a reduction of best corrected vision. Whatever the best glasses you give, their vision is not corrected. That is due to abnormal development of the visual development problem in a visual cortex. If you look at the ocular central nervous system, maybe normal. Like if you have a squint, if you correct it later, you can't correct the amblyopia because the brain development has already gone in the wrong direction. Late squint surgery, like in adults, sometimes we do cosmetic squint surgery. It doesn't improve vision. But in a child, if you see a squint, you do early surgery and together with the occlusion therapy to prevent visual disability. That is why it is important for you to know that. I have seen doctors sometimes telling the patients, the parents of the squinting child, wait for a while, this might get better on its own, so no need to go immediately. But don't ever do that mistake. Always squints are very important. It may be a neurological defect, it may be an underlying eye problem like a retinoblastoma, even an eye tumor occurring in children. So never ever delay squints, right? Never ever delay referral of squints. Squints are urgent referrals. Right, how do you manage squints? Now, this child has esotropia, and if you give the correct pair of glasses, the eyes have come back to normal on its own. Right, this is what these doctors sometimes refer to as may correct on its own. But if you don't correct it early, this child, even though the refractive correction is correct, the squint and the amblyopia will not get corrected. But if you catch the child early enough with the poor vision in the left eye, what you do is you cover the other eye. This is called the occlusion therapy. Now, easy to understand this. Now, if you are a house officer in one ward, and if you are not working hard, if your friend is not working hard, if you keep on working hard, nothing happens. If you stop working, the other person may have to work. Don't do that. But this is how the occlusion therapy works. The eye that is not good, should be forced to work. This can be done with spectacles and a physical occlusion, or sometimes instead of physically occluding this, you can put something like atropine, which dilates the pupil and the vision becomes blurred in that eye. So they have to develop this eye to see better. Right? And in some cases, we had to do surgery. You can see, I'm not sure whether you can identify, this is the cornea. This is the eye, the upper lids are here. You can see the lashes. We have put a speculum to separate the lids, and the conjunctiva is open, and you can see the muscle. This is the end of a muscle, which is now being separated from its original site, and it's being stitched onto this side. So these are muscle surgeries with which you can correct squints. Like the small children, you have to manage them early, but sometimes for adults with diplopia also you have to do something to correct diplopia. The most important thing is imaging and referring them to the neurosurgeons if necessary, neurologists if necessary, and also sometimes you can use prism incorporated spectacles. So that the prism will deviate the image, so the patient will not complain of diplopia. Then sometimes you can use botulinum toxin to the overacting muscle. When one muscle is underacting, you give the botulinum toxin to the overacting muscle, so that the images are brought together. And sometimes you may have to, in long-standing cases, if the patient has uncompensated diplopia, if the patient is very distressed by diplopia, you can do muscle surgery. That's the end.